Uh, oh, there we go. Hello, everyone. My name's Dr. Orlando Maldonado. I'm one of the PGY2 residents here at U of L. Let me get my screen share up so everyone can see my presentation. Actually, hold up. All right. All right, off to a good start. Let me make sure I have it in presentation mode here. Okay, there we go. Sorry about that. Like I said, my name is Dr. Orlando Maldonado. I'm one of the PGY2 residents. I'm going to be talking to you all today about a meta-analysis looking at buprenorphine versus methadone in opiate use disorder. And then we'll have a bit of a discussion and questions at the end. So to start, objectives for today, just kind of discuss the impact of opiate use disorder, understanding of current treatment modalities. I'll kind of give a brief overview of opiate use disorder and current treatment options. We'll take a look at the journal article and kind of go over the findings and discuss what they mean, and then we'll discuss the takeaways from the article and potential future directions of treatment for opiate use disorder, and kind of go from there. Just so to start, a bit of background on opiate use disorder. As we all know, there's a pretty significant burden and pretty high prevalence of opiate use disorder. In 2017, it was estimated that there were about 40 million people globally who were diagnosed with opioid use disorder. And of course, that data is a few years old. There's a pretty significant, health burden related to opioid use disorder. There's fatal opioid overdose, non-fatal opioid overdose leading to hospitalization and other illness, and then an increased risk of infectious diseases, including HIV, hepatitis, cellulitis, endocarditis, and especially recently with, a wider, widespread fentanyl use that's, only contributing to that. There are other consequences that include decreased quality of life, increased physical and mental health burden, increased interaction with the criminal legal system, a lot of problems, that are caused from opioid use disorder. So that's why, finding effective treatment for it is so important. And then the definition of opioid use disorder, I won't get too bogged down in this, but essentially, a problematic pattern of opiate use leading to impairment and distress manifested by 2 of 11 symptoms or criteria within a 12-month period, including physiologic symptoms like tolerance, withdrawal, craving, and then kind of social symptoms like taking extra time to acquire the drug or going out of your way to acquire the drug, failure to fulfill major role obligations because of the drug, et cetera. And then a brief talk about opioid receptors. So there are 5 opioid receptors. 3 of the main ones are the mu opioid receptor, delta, and kappa. There's also nociceptin and zeta. For our purposes, we'll mostly be focusing on the mu receptors. That's where a lot of the opioids and opioid agonists that are used to treat opioid use disorder act, or their primary mode of action. So the mu receptors bind to beta endorphin and endomorphin 1 and 2. The mu1 receptor is thought to be largely responsible for analgesia and dependence in opioid use disorder. The mu2 receptor is responsible for a lot of the euphoria and the dependence, as well as some of the side effects that we see from opioid intoxication or withdrawal, respiratory depression, meiosis, decreased digestive tract motility, and constipation, particularly when they're activated. And then the mu3 receptor is involved with vasodilation. And then just briefly, the rest of the receptors, there's the kappa receptors that bind to dynorphin, also involved in analgesia, diuresis and dysphoria. The delta receptors bind to enkephalins, and then play a role in analgesia and gastric motility. And then nociceptin receptors bind to nociceptin and have an effect on analgesia, and then also hyperanalgesia. And then zeta receptors are thought to help regulate developmental events in a variety of cells. And so to kind of go over treatment of opioid use disorder, 3 medications are approved for opioid use disorder treatment by the FDA. There's methadone, buprenorphine, and naltrexone. There are a lot of other options that have been trialed or investigated, but for the most part, it seems to be like methadone and buprenorphine are the main opioid agonist options. Other options have been tried, like slow-release oral morphine, metragenine, which is an indole alkaloid that has effects on opiate receptors, as well as dopamine and serotonin receptors, and methacinomoxin slash methadone is a synthetic stimulant. So it's interesting to see what people have tried for possible options. There are, of course, non-medical forms of treatment, including therapy, cognitive behavioral therapy, motivational interviewing, group therapy. There's other social support groups like NA, Alcoholics Anonymous, Smart Recovery, and then intensive outpatient programs and residential treatment programs as well. So to kind of start, a little overview of methadone. It is a full agonist at mu opioid receptors, which is why it's used in opioid use disorder. It also induces other opioid receptors. It also acts as a non-competitive antagonist at the NMDA receptor. So there's some thought that it might add some benefit for neuropathic pain. It has a fairly long half-life of at least 24 hours, but anywhere from 24 to 36 hours. Then it's primarily metabolized in the liver by the cytochrome enzyme system, mostly CYP3A4, but also 2D6. And then just an overview of dosing, usually started around 30 to 40 milligrams per day, and it can be increased by 10 to 20 milligrams per week. Most patients see, an optimal stable dose somewhere within the range of 80 to 150 milligrams every day. Because methadone's a full opioid agonist, there is a risk for respiratory depression, and there is a risk for misuse potentially. So usually patients are started when patients are induced on methadone treatment, it requires daily visits to get a dose. But of course, depending on how the patient progresses and the physician and the clinic's policies, eventually, if patients are stable enough, there is the option of doing take-home doses. And then for buprenorphine, so buprenorphine is a partial agonist at the mu opioid receptor. So instead of it being a full agonist, it doesn't activate the receptors to the same extent as methadone or other full agonists like opioids of abuse or pharmaceutical or prescribed opioids. And then it acts as an agonist at the delta receptor and antagonist at the kappa receptor. It also has a long half-life, around 38 hours, and it is also metabolized in the liver. One thing with buprenorphine is it does have a very low oral bioavailability due to first-pass metabolism. So you'll typically see sublingual administration of pure buprenorphine or another form of administration rather than oral. And then buprenorphine dosing, so it is dependent on the formulation. I'll get into that in a second. But for sublingual buprenorphine, one note, patients should be in mild to moderate withdrawal before induction. Like I said, because it's a partial agonist, you can induce withdrawal in someone if you give it too early and they still have enough opioids in their system. It's typically started at a small dose around 2 to 4 milligrams and then observed, and then you can kind of gradually increase the dose until the patient's looking more stable. And then most patients will find a good dose range of 8 to 16 milligrams per day, but the max dose per day is about 24 milligrams. And then here's some formulations of buprenorphine. One of the really well-known ones is Suboxone. It's a combination of buprenorphine and naloxone. The reason for adding naloxone in there is naloxone is an antagonist at the opioid receptor, and so it can prevent misuse of buprenorphine. Theoretically, if one were to try and inject buprenorphine, for example, or Suboxone, for example, the naloxone would cancel out the effect and eliminate the risk of any respiratory depression or any bad outcomes. There is Sublocade, which is the subcutaneous extended release form that I'll talk about more on the next slide, and is also involved in the study. And then there's Subutex, which are just sublingual tablets of sublingual formulation of buprenorphine, a film, I believe. And then there is a tablet formulation, which I haven't really seen used much. And then there's Probuphine, which is a 6-month implant, and that's something that'd be interesting to look more into as well. I haven't seen that used clinically. So like I mentioned, this is Sublocade, the brand name of extended release buprenorphine. It's an extended release injection that's subcutaneous. It's indicated for patients who have been stabilized on transmucosal buprenorphine. Usually start off with 300 milligrams once per month to induce, and then you do maintenance on 100 milligram injections. And then theoretically, you can do 300 milligrams a month for maintenance, but the clinical trials don't show any increased efficacy compared to 100 milligrams. So here is the article I'm going to review with you all today. It was published in Lancet Psychiatry in May of this year. Here's the title, obviously. It's Buprenorphine versus Methadone. It's a comparison of randomized and observational studies looking at the two medications for a wide variety of outcomes. So the aim of the study is to, like I said, compare buprenorphine and methadone in the treatment of opioid dependence across a wide range of outcomes, which I'll go over in a bit. Just first methods, they looked through a number of databases listed here, studies from the start of the database to August 1st of 2022, including both randomized controlled trials, observational studies, and I think also cohort studies potentially of adults with opioid dependence, comparing the treatment of the two medications. The criteria, so inclusion criteria, studies including adults 18 years or older with opioid dependence, including illicit or pharmaceutical opioids. They covered a wide variety of settings, both inpatient and outpatient, including prisons, residential rehabilitation facilities, and primary care facilities. Some of the exclusion criteria, patients younger than 18 years old, so not adults, trials including exclusively pregnant women, and then use of buprenorphine for detoxification. For the outcomes, the primary outcomes they looked at were retention in opioid agonist treatment at 1, 3, 6, 12, and 24 months, so 2 years out from the initiation of treatment. Adherence to opioid agonist treatment, which they define as going to appointments as scheduled, taking the medication as scheduled, and then extra medical opioid use, so use of opioids while in opioid dependence treatment. And then they had a pretty long list of secondary outcomes, which include use of other drugs, so cocaine, methamphetamine, cannabis, et cetera, withdrawal, craving, criminal activity, overdose, mental and physical health outcomes, sleep, pain, global functioning, suicidality, and self-harm, and then adverse events from the medication. For data analysis, so for the primary outcome, mainly treatment retention, they extracted all the data from the study separately for buprenorphine and methadone, pooled together randomized controlled trials and then observational studies and the cohort studies into two separate groups and compared the two. Whereas for the secondary outcomes, they only included studies that directly compared methadone and buprenorphine. And then kind of a deeper look at the data analysis. So for binary outcomes, the portions were calculated as participants who did or did not experience a given outcome. For continuous outcomes, the group means and standardized deviations were extracted, and then they calculated it if need be. And then they use some pretty complex statistical analyses here, Cohen's method, the other two, which I'm not even going to try and say. If I wish I could give you a coherent explanation of what these statistical methods are, but I'm not the best statistician, so I'll leave it at that. But to go over the results of the study, this here is a graph of treatment retention that they found from randomized controlled trials on the left, and then observational studies on the right. The y-axis is patients retained in treatment. X-axis is time from induction of treatment out to 24 months. Looking at the randomized controlled trial data here, one thing that stands out is it seems like methadone fairly consistently seems to have a higher rate of retention compared to sublingual buprenorphine. Something that's interesting is the extended release buprenorphine seems to have similar rates of retention in treatment compared to methadone. However, you see the pretty wide error bars and confidence intervals there. It seemed like they didn't have quite enough data for that to be statistically significant, but at the very least, the data they did have seemed fairly promising for the extended release. And then likewise with the observational studies, in this one, there wasn't quite as much separation between methadone and sublingual buprenorphine. They have fairly similar retention and treatment rates. The extended release buprenorphine seemed to do better in comparison to both. However, once again, they were pretty limited in terms of the data they had available on extended release buprenorphine. And so they weren't able to make any statistically significant conclusions, but it did seem a bit promising. Going to go through a bunch of tables here that has the outcome list on the side, and then the bunch of data on the left is randomized controlled trials, the bunch on the right is observational studies. This first set here is pretty much what I relayed in the graph. For randomized controlled trials, you saw pretty consistent improved retention and treatment in methadone compared to buprenorphine. And then same with the observational studies was you did see methadone do better compared to buprenorphine there as well. In terms of adherence to treatment, so doses taken as prescribed, you didn't really see a significant difference in either, but they were fairly limited on how much data they actually were able to get. There's only one study in on each side, and then kind of same for dosing visits attended. Only 2 RCTs that evaluated that, and that didn't show a favor one way or the other between methadone and buprenorphine. And then extramedical opioid use. If you look at the continuous measure by urinalysis in the randomized controlled trials, there were 3 RCTs that evaluated this and seemed to favor buprenorphine over methadone, but otherwise there doesn't seem to be a significant difference between buprenorphine and methadone in terms of extramedical opioid use, at least from the rest of the data available. And then to go into the secondary outcomes, which there are a lot of, in terms of use of other drugs, there was one RCT that found self-reported use of cocaine was decreased in buprenorphine compared to methadone, but otherwise not a significant difference for cocaine, cannabis, or amphetamine. And this is kind of small, so I apologize, but to continue looking at other drugs, including benzodiazepines and alcohol use, really the main difference here is you see the self-reported use of alcohol in observational studies. There seems to be a decreased rate of alcohol use in methadone versus buprenorphine treatment. For craving, no significant difference in the RCTs, but observational studies seem to favor buprenorphine for a decreased craving as rated by scales. No difference noted in withdrawal symptoms or sleep quality or pain. Mean treatment satisfaction or global functioning as well. For mean treatment satisfaction, from one observational study, there seemed to be a difference in buprenorphine, but pretty limited data on that. No difference in terms of engagement with the criminal justice system. It seemed like there were 1 or 2 randomized controlled trials that evaluated those, but didn't find a big difference. And then in terms of mental health outcomes, the big difference here was that anxiety symptoms seem to be better in buprenorphine treatment compared to methadone. And then almost done here, the physical health. They did find, in terms of cardiac dysfunction, in terms of QT intervals, there was a difference in both randomized controlled trials and observational studies. It seemed that buprenorphine had better outcomes in terms of decreased cardiac dysfunction. And then one observational study, pretty large, with 20,000 participants, found that hospitalization was decreased in methadone treatment compared to buprenorphine. And then in terms of adverse events of the two medications, there wasn't a significant difference between either of them based on the rest of the data they looked at. So to kind of summarize that up, retention didn't necessarily statistically significantly differ at 1 month, but methadone seemed to have better retention at subsequent time points up to 24 months post-entry treatment. In a small number of observational studies, the extended release buprenorphine had better retention than both methadone and sublingual buprenorphine, but a lot of uncertainty around the estimates, kind of like I pointed out with the graph there. So 3 randomized controlled trials showed lower extramedical opioid use in buprenorphine, but otherwise for the rest of the data, they didn't find a difference between the two. And then in terms of the secondary measure of other substances, there seemed to be a lower prevalence of cocaine use with buprenorphine and a lower prevalence of alcohol use with methadone, at least based on the data they had. And then, like I said, the RCT that studied cardiac dysfunction did seem to find decreased cardiac dysfunction with buprenorphine. And then one large observational study showed a lower rate of hospitalization with methadone. So now kind of discussion to go over all of this and what it means. Just really quickly taking a look at the patient population of all these studies. They compiled it all, and there was a skew towards male patients. 66% were male. The overall mean age was 37 years old. And the randomized controlled trials and the observational studies are pretty spread out across the world. They didn't seem to include any in South America for some reason, but they seem to hit studies in pretty much all of the rest of the world. But there is a pretty significant proportion of these studies that were done in North America and Western Europe as well. But it is good to see some studies that were done elsewhere. So I think their findings hopefully are fairly reliable in terms of relating them to patients that we see here. Some limitations of the study. So in terms of the randomized controlled trials that they found, they were often limited by small sample sizes and therefore low statistical power. And then the observational studies had much higher numbers of participants, but there was a high likelihood of selection bias, who is chosen for treatment of methadone versus buprenorphine, and as well as confounding. And then there were few studies that studied extended release buprenorphine, and only one study that directly compared extended release buprenorphine to methadone. And then limited data on more specific populations. That kind of all the data was clumped together, but it was difficult to distinguish, is there a difference between certain ethnic groups or more specific age groups? And then, again, not quite as much data on non-consumption outcomes such as treatment satisfaction or quality of life. And so to kind of go over the author's conclusions, it seemed pretty reliable that retention was better with methadone than it was with buprenorphine over the course of 24 months. Kind of inconsistent or not enough evidence for a lot of the other outcome data. Some limited evidence. There were a few things that buprenorphine seemed to have an advantage over methadone on. I think one of the notable ones is the cardiac dysfunction, but definitely room to expand evidence for a lot of other outcomes. And so basically the author kind of concludes that, perhaps buprenorphine shouldn't be, considered first line by default, given it seems to have lower retention and treatment and not, clear evidence of strong benefits in other areas. And then I think one thing he noted was that extended release, they noted, is that extended release buprenorphine seems promising, but there's limited evidence on it. However, some of the evidence they did find seemed that it might have better retention than either um, methadone or buprenorphine. And then just some kind of further applications or next directions to go with all this information. I think more studies looking at the efficacy and tolerability of other formulations of buprenorphine, especially the extended release. It is good to see some of that promising early data that retention might be higher, and then some of the benefits that you get from buprenorphine, you'd be able to get from the extended release with higher retention and treatment. And then, more studies examining other outcomes. Like the author mentioned, there were a lot of secondary outcomes where it was hard to find a lot of data on, including quality of life, interaction with the legal system, other health problems, to get a better sense of the real world impact of opioid agonist treatment, and which is better. And then, looking into other ways to improve retention. I kind of touched on these a little bit earlier, but there are a lot of other multimodal aspects to treatment of opioid use disorder, including, therapy, support groups. I think, potentially considering integrating technology into opioid use disorder treatment is a possible future direction. I did stumble across one study as I was, kind of putting this together that was trying to study using a mobile application to provide either a community reinforcement approach or cognitive behavioral therapy to patients with opioid use disorder, where the only requirement is that they have a phone and access to internet. So I think, potentially if we can find a way to use technology in a meaningful way, we might be able to reach a lot more people. And so now, if anyone would like sources for the presentation, just reach out to me, send me an email, and I can get you those. But that's the end of what I have in terms of my presentation. So I'll open it up to any questions or discussion at this time.
Okay, so I'm going to move in several people to be panelists, so just give me a second. I think Dr. Oliva raised his hand.
Hey there, let me know if you can hear me. I was still having problems with my Zoom when I first started. So I thought it was a really good presentation, Orlando. I came in a little bit late, but I wonder if you talked at all about studies looking at access, specifically between buprenorphine and methadone. I'm not sure if you've ever been to a methadone clinic, but the regulations around methadone are obviously a lot more strict than buprenorphine. The DEA actually methadone is one of the few drugs where the DEA actually has complete regulation of it. They have really weird rules that the glass and that methadone clinics have to be bulletproof. They have very strict dispensing requirements, and obviously people have to go in person every day to dose methadone in the morning, except on weekends. And that's I always think that has obviously very significant impacts on the ability to get methadone and get treatment. And while I know randomized controlled trials are a little bit more controlled environments, I wonder what real world studies and the like show about treatment retention and access regarding that.
Yeah, that's a really important observation. I touched on it a little bit at the start, that obviously the access to methadone is much more heavily restricted. But you're right that definitely does make a pretty significant impact. And so I think that's where they found some limitations the RCTs, and that it is a little bit more of a controlled environment. I think some of the hopefully the observational studies gave a little bit more of a sense of in the impact of the real world actual access to methadone. But of course, that kind of can possibly lead to selection bias and other confounding variables with the studies. But that is a really important observation. Is obviously it's important to consider actual access to the medications as part of if they're efficacious or not. Yes, I see. Dr. Stewart has his hand raised there.
Sure. Can you hear me?
Yes, I can hear you. Okay.
Good. Yeah, I didn't know you were giving a talk on this today, so this is good. I was very pleasantly surprised to come in and see this talk, and found it interesting. I appreciate you bringing this in, and you did I think you did a very good job. So it's consistent with my experience and maybe yours too. I think the methadone seems to do better at I think engagement and getting people quickly into treatment, and nothing seems to be that great at retention. And we're dealing with it's just such a difficult problem, but I found it to be consistent with what I've been experiencing. For a long time, buprenorphine has been sort of going downhill in effectiveness in my experience with, it was really great for prescription opioid use disorder, people who were using prescription pills. But when we moved to heroin and IV drug use, the efficacy really dropped off for keeping people in treatment, dealing with cravings. And we're doing lots of things to try to deal with that. And we maybe made some inroads, but methadone's been there for a really long time and has a really strong record with IV drug use and reducing IV use for a really long time. So it should do well. And Sublocade does seem to be have some advantages. We're improving retention when we're in our programs with Sublocade. There are some halfway houses in Louisville that are requiring if you're going to be on a buprenorphine, or you have to be on Sublocade to be in their halfway house in Louisville. So that's an indication too, I think, of sort of this hope and maybe experience that it's doing better. But the other problem is, and just pontificate away, is methamphetamines. And nobody just does one drug. They all do 7 or 8, right? So then you're dealing with that whole problem. That's a real confounder to know, what are you really accomplishing? I'll say this to Art's point about access, which always comes up around methadone. It is harder to get on methadone. We used to have 3 programs in Louisville for, we had the Moore Center, we had the Southern Indiana Treatment Center, and we had the CVH, or Center for Behavioral Health. And that was it. We had 3 programs. And it certainly was, there was but now we have more. It seems like we have more programs that are doing methadone than we did before. But I mean, the demand is a lot higher too, and there is a long wait. It depends, and so it's not. But we have several programs. The Moore Center did close, but we had programs. The reason they closed is there were so many private programs being opened up, they couldn't staff the Moore Center because all the staff were being hired by these other programs. So I know there's more methadone treatment than any time I remember. And I've always thought we have a methadone program at the hospital. Some hospitals do that, and it's a lot of obviously a lot of work to do that. But it's a great topic, real timely. What do you think? Yeah, what do you think? Yeah, and say something about the amphetamine, how amphetamines are, the 4th wave of this, and how that confounds it, if you wouldn't mind.
Mm-hmm. Yeah, I'm sure you've got plenty of experience with that. But yeah, it's I think anybody going through inpatient rotations or SARP or EPS has seen there's such a high prevalence of methamphetamine use out there, and I mean it definitely does complicate the picture. I mean you're right. Unfortunately, a lot of patients in substance use aren't only using one substance, so it does make the treatment of that more difficult.
It didn't used to be like that when we first had buprenorphine. I mean, really, the data around 2000, people were doing, they had one thing they did a lot more commonly. But now, I mean, that's a big change I see.
Mhm. Yeah, definitely. Yeah, and it definitely complicates treatment as well. So, yeah. Dr. Bonomo, would you
Yeah,
like
thank you, Orlando. That was a wonderful presentation. This is almost as much a discussion as it is a question. What are your thoughts on why retention was better in the methadone group? And one thing in particular I'm curious about, was there any like average on the maximum dose of Suboxone that people were allowed to be given in the studies? The reason I asked that is, I was listening to a podcast the other day about this topic, and there's a guy out in California who said he's been giving sometimes upwards of to 40 or 50 milligrams of buprenorphine, just because with people that are chronically dependent on fentanyl and other opiates, he hasn't found a response to lower doses. And it's obviously not guidelines, but I do almost wonder if maybe the retention problems is that most people don't go above 24 on Suboxone.
Yeah, that's a really good point. The authors actually touched on it in the paper where they mentioned that it's hard to find like dose dependent data for retention. And so that is a really good question. Is that is part of the contribution of the lack of treatment retention to buprenorphine that people don't go above a certain dose, especially with so some things like fentanyl and other opioids. I think that's a really good question that we probably should look into more. Is that is it possible that buprenorphine would have better treatment retention and still be relatively well tolerated if people did go to higher doses? Because I've also seen a few things that people have been saying there are better responses in a lot of chronic opioid users with higher doses of buprenorphine. So I think that's a really good thought. I would love to see some if they had a better feel for the typical doses used in these studies to see if it had a good impact on retention. But that's a really good thought. Yeah.
Hi, Orlando. This is Liam. I think your presentation was excellent. This is a very important topic. This is more of a comment. For buprenorphine is pretty much one of the best studied medications in terms of number needed to treat. I think it's 2. That's probably the highest number for any medicine in all of medicine. I do think that the stigma and um, just the lack of competency and awareness by a lot of physicians who practice in the real world and see our patients and don't know if they should start buprenorphine or discontinue it if somebody is being admitted to the hospital for like a surgery or an operation or some kind of infection, because that stigma just makes them treat our patients like they're not human. I just had last month a patient at Norton Hospital get consulted overnight, and then they cancel the consult whenever I recommended that they don't start buprenorphine. So some of the ways that hospitalists especially treat people with opioid use disorder in the hospital is very frustrating. And I think we need to educate them more. Thank you, Orlando.
Yeah, thank you for that comment. I agree. I think there definitely is a pretty major stigma around opioid use disorder, and it definitely impacts the way patients with opioid use disorder are treated, and in hospital settings and otherwise. And I think there would be better outcomes if other providers were more comfortable and more knowledgeable about prescribing buprenorphine or other medications for treatment.
If any of the medical students have questions, please raise your hand. I think someone raised their hand, so I'm going to move them over.
I have a question, and this is kind of open to everybody. So I was just really struck by the data of the population breakdown in the studies, and like the 66% male versus 33% female. And I don't know where, I'd have to look back at all the studies or whatever, but trying to figure out, in normal practice, people who are prescribing, if you find that there is a discrepancy in the report, like the patient population and gender, and, is that maybe like a bias on our end or a bias on the patient end? And I didn't know if anyone had looked at that or come across that in any studies.
Yeah, I'd love to hear Dr. Stewart's thoughts on this, as I'm sure he's got more clinical experience with it. That's a good question. I'm not sure. I couldn't find a clear answer for why there was a male shift like preference with the all the studies. I didn't know if it's a higher prevalence of substance use in men, or if there were more men in opioid agonist treatment. So I don't unfortunately have a great answer for that, but I'd also love to get a better sense of that, because I think that's a really good, really important thought.
I could just take a few guesses at it. I don't know why it really ultimately why that is. I would guess, were some of the studies done in what were the settings that the studies were done? Were they all outpatient?
So I think there were a range of studies. Some were outpatient, but some were inpatient. I think they also included prison studies, inpatient facilities and rehab facilities as well. So it was kind of a wide variety of settings.
That's what I would think. I would wonder about that, and I think there's a bias in research in general, and still a residual bias towards having male subjects, there, and for a lot of different reasons. But I don't know. I mean, because go out there and the population is that's not how it looks in treatment. It's not 66% men, and I treat a lot of women, and but I don't know the answer. I have to think about that one.
Thank you.
Yeah.
I have a small comment on this answer. So there were few studies which were from the international, like Europe and Asia. And then coming from India, the only population that we had that used opioids were males. There were hardly any females using opioids. I know that's not the scenario in North America, but I don't know if the situation is more skewed in other parts of the world.
It's interesting.
That is a good thought. Yeah, because a lot of the, obviously a lot of the studies were in North America or Western Europe, but there were a lot of studies from other countries as well. So perhaps that plays a role. Thank you.
Any last comments, questions before we end the presentation?
Great presentation, Orlando.
Thank you.
Yes, thank you so much. That was very, very informative.
Awesome job, Orlando.
Thanks, guys.
All right, everybody, have a good day.